non-communicable diseases as overall, but India, we are celebrating research. So Indian research, original articles, and so many things we are doing with teams. We are having so much research papers such as a strength. So the value of meetings like this, webinars, is to update physicians, scientists, and endocrinologists worldwide. That's also to regarding updates which are happening. So we have lined up for you a good activity at academic feast, which includes the first half will include presenting 3 important research papers that have come up emerged in the last few years. The first will be from Kerala, that is from Lakshmi Nagendra. She will be touching on congenital hypothyroidism, targeted newborn screening and approach in this regard. And the second will be from Kolkata regarding PPI, proton pump inhibitors, and how it has been important for physicians. And the third one will be regarding Graves' disease and anti-thyroid antibodies. And after that, we'll have a panel discussion, which will be focused upon the personal medicine and how we can improve the care for thyroid patients. And it will be basically for the care of the thyroid, because we know that recent updates in thyroidology are there in the last few years, role of T3, suckling hypothyroidism, and many. So I think this will be a good journey. And along with me, the scientific coordinator is Dr. Joe George. Sir requires no introduction. Sir is a senior consultant working in Kozhikode, Android Institute. And to take us further, let me hand over the mic to Dr. Jabbar sir. Jabbar sir is the HOD, Head of Department of Trivandrum Medical College, Government Medical College Trivandrum, as also the President of the Endocrine Society of India. And he's also the Executive of the Indian Institute of Diabetes in Trivandrum. And welcome, sir. Over to you, sir. Please give us a welcome address, sir.
Yeah, good evening, my dear friends. Dr. Pramila, senior endocrinologist of our country, Dr. Sanjay, Dr. Lakshmi, Dr. Neeti, Dr. Nitin, and my student and friend, Dr. Joe, and esteemed guests online, probably little offline also. I'm very happy. And before starting the introductory remarks, I want to congratulate my friends, Dr. Joe, Dr. Mohan. Of course, under the guidance of Dr. Hari, they could arrange a beautiful meeting of thyroid or celebrating World Thyroid Day within 2 to 3 days. I think so they deserve for a big applause for this marvelous activity, I would say. And without any hindrance, things are happening beautifully. So I wanted to give very, what should I say, heartfelt appreciation to my friends. My dear friends, the thyroid-associated diseases, I got a paper by Dr. Kochupille et al. Published in 2000. It's very interesting data. I think if you have time, you can go through that. And regarding the prevalence of thyroid disease, what is documented in that paper by Kochupille sir is endocrine diseases, among endocrine diseases, thyroid diseases are leading. It's around 40% in this cohort. And diabetes comes in the second endocrine problems. And subsequently also probably with the lot of heated discussions. In Germany, I think they decided to go for some sort of thyroid day or World Thyroid Day. And first thyroid day was conducted in somewhere in 2008 also, and subsequently most of the centers and most of the places, most of the professional forums, they are conducting World Thyroid Day. And I want to urge my friends, young blood, okay, today I got a message in Times of India. The thyroid awareness note has been written by a NON allopathic doctor, okay. So what I wanted to say that, see, thyroid diseases are very common and increasing like anything, rocketing like anything. And eventually, these thyroid diseases are treated by many specialists, including non-allopathic specialists also. My feeling is a lot of homeopathy physicians are treating thyroid problem, let them treat. But my feeling is we should take the lead for treating or giving awareness or giving knowledge in the field of thyroidology. I urge all associations, including our Indian Thyroid Society or International Thyroid Society, whoever, ESI, to take the lead. You can conduct various programs for giving awareness to our patients with thyroid diseases. Yet another interesting thing, so whatever said and done, lot of mismanagement is also happening. Last week, we got a case in our Trivandrum Medical College. Patients got a simple thyroiditis as per my knowledge. And the one fellow, probably English doctor wanted to do some sort of surgery. So what I want to convey the message is the awareness is very important, not only for patients, even for doctors, even I would say for endocrinologists like me, because we are all probably a little older generation. So we have to update our knowledge. We have to the knowledge or impart the knowledge to public as well as our fellow doctors. And I think ESI and Indian Thyroid Society, of course, most of the ESI members and the ITS members are same. Now, tomorrow we have a beautiful meeting happening at Bali. That is IOTA meeting Thyroid Society, where our friends are there. Even our founder president is there. The current president is there. Other eminent personalities are there. They will be joining there. So with this introduction, what I feel simple, will follow and will give the awareness regarding thyroid issues to public as well as our friends. Okay, for that, may God bless you. We'll have the courage and we'll have the capacity to do that. May God bless you. Let me conclude. Over to organizers for conducting the meeting continuously. Thank you very much.
What a beautiful message, sir. Thank you, sir. It inspires all of us. Yes, sir. Thank you, sir. It inspires all of us to work harder, and I think effort should be done. So I think let us start with some research papers. First, I will just get the introduction of the speakers. Let me just share the screen. Is the screen getting visible? Is the screen visible now?
It's coming.
Yeah, it's slow. The screen is visible now because I think that it's internet problem. Yeah, so it's not full screen. So I will just introduce Dr. Lakshmi Nagendra. She is Associate Professor and Head of Department of Endocrinology at JSS Academy of Higher Education and Research, Mysuru. She was awarded recently with the Pierre Muir Young Scientist Award at the IOF, that is International Osteoporosis Foundation. And she is also awarded so many laureates. You can see RSSDI Young Endocrinologist Par Excellence Award only last year. Then ESI Yuva Ratna Award last year, the International Travel Grant also by the ESI 2023, and also the ESI AV Gandhi Award for Clinical Excellence in Endocrinology 2020. She has been having so many publications, over 40 in the index journals. Research interests include osteoporosis, gestational diabetes, systematic review, and meta-analysis. And she's actually a very good friend of mine. So over to you, Dr. Lakshmi. Lakshmi will actually present a very important research, which I was also part of. It is done in Amrita Institute of Medical Sciences, Kochi, and it is regarding newborn screening, congenital newborn screening. So over to you.
Thank you, sir, for that very kind introduction. And are my slides visible?
Yes, please go ahead. Yeah.
So happy World Thyroid Day to all of you, and it's a pleasure to be celebrating with the Endocrine Society of India with Indian research. So thank you all of you. Thank you for giving me this platform to present my research. So I will be talking about targeted levothyroxine dosing in congenital hypothyroidism. And this work was carried out while I was a resident at Amrita Institute of Medical Sciences. So I would like to convey my gratitude to my alma mater and my department of endocrinology at Amrita Institute of Medical Sciences, who have been instrumental in this paper. So this was a paper that we published last year, the etiological profile, targeted levothyroxine dosing and impact of partial newborn screening in congenital hypothyroidism. We published the experience that we had in over 233 patients with congenital hypothyroidism over a 10-year period. So just to give you a brief introduction, we know that congenital hypothyroidism is the most common cause of preventable intellectual disability. And when we talk about the etiology of congenital hypothyroidism, it's mainly thyroid dysgenesis or thyroid dysharmoniogenesis, which constitute the main etiologies in congenital hypothyroidism. So levothyroxine is usually commenced at 10 to 15 microgram per kg in the neonatal period. All the guidelines, if you look at ISPE guidelines or American Association of Pediatrics, Indian Association of Pediatrics, all of them suggest the same thing. Start with levothyroxine at 10 to 15 microgram per kg as soon as the diagnosis is made. And serum T4 or FT4 is measured at 2 weeks and then at 1 month and then at regular intervals thereafter. Then babies with the possibility of congenital hypothyroidism are re-evaluated at age 3 to assess the need for lifelong therapy. So this has been the standard of care. But what is the problem with this? The current recommended initial dose of 10 to 15 microgram per kg has a wide dosing range and frequently leads to over-treatment or under-treatment, requiring frequent modification in doses, as you might have seen in your clinics. So, for example, dose of 10 to 15 microgram leads to a large dosing range and translates to huge dose differences. If you take a child weighing 4 kgs who's just been diagnosed with congenital hypothyroidism, a dose of 10 would lead to 40 micrograms per day, and a dose of 15 micrograms per day would lead to 60 micrograms. So if you do you start this patient on 10 micrograms per kg or 15 micrograms per kg? So if you actually translate it, it becomes the dose difference is actually 20 micrograms. So what exactly is the dose that you need to start this child on? So the optimal starting dose is still debated, and it is a gray area. So we wanted to explore targeted dosing of levothyroxine based on etiology in congenital hypothyroidism. We wanted to see if you give a different dose for dysgenesis, or if you give a different dose for dysharmoniogenesis, does it lead to better outcomes in patients with congenital hypothyroidism? So this was a retrospective analysis of medical records of 233 children with congenital hypothyroidism referred to a center between January 2009 and December 2019. And majority of these babies were diagnosed to have congenital hypothyroidism elsewhere, and they were referred to a center for further management. So venous confirmatory TSH of more than 20 before age 2 weeks and more than 10 after age 2 weeks with low T4 was defined as primary hypothyroidism, and normal T4 was defined as isolated hyperthyrotropinemia. And both were included as congenital hypothyroidism, and they were initiated with levothyroxine treatment. So all three children were treated with levothyroxine sodium at a dose decided by the treating physician based on standard guidelines. And standard instructions were given to dilute the tablet in breast milk or plain water and to be administered using an infant's feeding foam. So data on undertreatment or overtreatment were collected based on follow-up thyroid function tests, and children with suspected dysharmoniogenesis were given a trial of therapy at the age of 3 years according to the judgment of the treating physician. So these were our results. 233 children with congenital hypothyroidism were included in the study, and the effect of newborn screening was also seen in this study. A partial newborn screening for congenital hypothyroidism was established in Kerala in 2012, where newborn screening was established in some of the government hospitals and then in 100% of the government hospitals by 2013. So when we looked at the median age at diagnosis of congenital hypothyroidism before 2013, that is before partial newborn screening was established, the time taken to diagnosis was as long as 45 days. So if you look at the interquartile range, it was up to 180 days even. So that was a long period before congenital hypothyroidism was diagnosed. And after the introduction of a partial newborn screening in Kerala, the median age of diagnosis came down to 10 days. From 45 days, it came down to 10 days. So even the introduction of a partial newborn screening in Kerala brought down the age at diagnosis significantly, and we suggested that if newborn screening cannot be implemented on a full scale in some regions, I mean, it should be implemented in everybody, but even with a partial newborn screening, the age at diagnosis reduced significantly. And when we looked at the etiology of congenital hypothyroidism, dysharmoniogenesis was the most common etiology, which was 57.5%. This is quite contrary to the Western literature, which says that dysgenesis is the major etiology of congenital hypothyroidism. So there are reports from Western literature which say that dysgenesis accounts for up to 70% of patients with congenital hypothyroidism. But in our study, we saw that dysharmonigenesis was indeed the most common cause of congenital hypothyroidism. And when we looked at permanent and transient congenital hypothyroidism, a total of 77 children with a gland in situ had completed 3 years treatment, and levothyroxine supplementation could be successfully stopped in 35%. So 35% of patients who had, 35% of the patients who had a gland in situ had transient congenital hypothyroidism and did well off therapy. And we had data on 54 children with dysharmonigenesis who had completed 3 years and had at least one follow-up at our center before 3 years of age. And with this, we wanted to see the doses at 1, 2, and 3 years of age, which could be a predictor of permanency of congenital hypothyroidism. Now, I know that we say that we cannot take the baby off treatment until the baby is 3 years of age, but we see a lot of parents who are worried whether this is permanent, whether this is transient. So we wanted to come up with a dose at even 1 year and 2 years, which will predict the permanency or the transient nature of congenital hypothyroidism. And this was the dose cutoff. So at year 1, a dose of more than 2.75 microgram per kg, and year 2, a dose of more than 2.15 microgram per kg, and year 3, a dose of more than 1.85 microgram per kg predicted the permanency of congenital hypothyroidism, with sensitivity reaching up to 80% and specificity reaching up to 60%. So this was a good round figure to tell the patients that probably your child has permanent congenital hypothyroidism, even looking at the doses at year 1 and year 2. And when we looked at the etiology versus dose, so first when we looked at thyroid dysharmonigenesis, a dose upwards of 8 microgram per kg was often enough and very infrequently led to undertreatment in patients with thyroid dysharmonigenesis. So you can see that the dose of 8 to 12.9 microgram per kg led to undertreatment in only 6.3% of patients. But when we looked at thyroid dysgenesis, even doses of 13 to 18.5 microgram per kg lead to frequent undertreatment. That is, this led to undertreatment in about 75% of patients with thyroid dysgenesis. So obviously the dosing is different in patients with different etiologies, and patients with thyroid dysharmonigenesis require much lesser doses than would patients with thyroid dysgenesis. So the strength of our study was the large number of patients with confirmed congenital hypothyroidism from a single center, but there were several limitations of our study. The long-term neurodevelopmental outcomes of study participants are not known, and the number of patients with dysgenesis as the etiology of congenital hypothyroidism is very small in our study. So we suggest that further large-scale randomized controlled trials with larger number of patients comparing the range of starting doses in different etiologies of congenital hypothyroidism be done, and these studies also look at neurodevelopmental outcomes along with biochemical treatment outcomes. So to conclude, our data suggests that the gland imaging reflects a functional status of the thyroid gland, and the in situ thyroidal tissue, although insufficient to support the full daily requirement in patients with congenital hypothyroidism, may have a small residual activity and produce a small amount of thyroid hormones. So based on our findings, we suggest initiating levothyroxine at the lower end of the recommended dose of 10 to 15 microgram per day in children with congenital hypothyroidism with gland in situ. But patients with dysgenesis may require doses upwards of 13 microgram per kg with more frequent monitoring to avoid undertreatment. Thank you one and all for your patient listening, and I would be happy to take any questions.
Yeah, thank you, Dr. Lakshmi, and I think it is a good presentation. Will you be here for some more time, or would you have some questions now only?
I think we'll take the question now only, isn't it?
Okay. Is there any questions in the panel now, Jabbar sir? Because I think we are getting questions from the users quite late, so we are picking those questions. Is there any other questions? Please, I think Dr. Nisha madam is also joining. So if I have any questions from the in-house team, please raise the question.
I think this study was conducted beautifully under the guidance from our Amrita team. And very clearly, Dr. Lakshmi conveyed the messages also. Probably you won't get any questions also from this. Okay.
Yeah.
So once again, I would like to thank my alma mater, Amrita Institute of Medical Sciences, and our whole department. Nisha ma'am is also here, whose guidance has been instrumental in bringing out this paper and many other papers like this. So thank you, ma'am, and thanks to the entire department.
Yeah.
Thank you, Lakshmi. So we'll move on, I think, with the permission of the chair. Yeah. So I'll just take the slide deck once again. So let me just open. Yeah. So the next next session is actually by Dr. Neeti Agarwal. Can you see the screen now? Because there's a network problem here. Screen is visible?
Perfect.
Yeah. So Dr. Neeti Agrawal has obtained her DM endocrinology from West Bengal Institute of Sciences in the year 2022. And she has done the study along with the first author, Avivar Avasthi and Partha Pratim from Kolkata. She's affiliated with the Department of Endocrinology, Medical College, Kolkata as senior resident. She has a good publication. She's upcoming endocrinology researcher with the areas of interest being adrenal disorders, young onset diabetes. So she will be shedding highlights on the role of proton pump inhibitors in the initial, how these are interfering with the management. So you can take over now. Thank you. Over to you. Can you make it full screen? Yeah.
Are my slides visible, sir?
It's coming slowly.
Okay.
For me, it's not yet visible. So you can try once more, because I think my screen just I closed my slides just now. So maybe you can once more reshare again. Maybe you can close this and share once more. Yeah. So the study was on proton pump inhibitors interaction with levothyroxine, in-depth analysis, and she published in the highest journal as well. So
Like visible at now,
yeah,
sir?
it is now visible. Try it full screen. You can press full screen. On the side of the screen, you will have, yeah. Now it's coming. Yeah.
Thank you, sir, and ESI for giving this opportunity to present this study entitled Study of Effect of Morning versus Nighttime Administration of Proton Pump Inhibitor on Thyroid Function Test in Levothyroxine Treated Primary Hypothyroidism, a prospective crossover study. So as per Indian data, around 40 people suffer from thyroid disorders, among which primary hypothyroidism constitutes around 11%. And as far as optimum target treatment is considered, so more than 50% of these patients who are treated with levothyroxine, they have their serum TSH more than the target range.
Neeti, your slide is not visible again. Can you just reshare?
Yes, sir.
Yeah. Go.
Maybe you can present like this only, because maybe once you are opening, make it full screen. It's not coming.
You can try once more, I think. Yeah.
Yeah, you can just one more maybe try. Yeah. I thought my network was problem. That's why I did not tell. Yeah. On the side of the screen, there will be a button where you can.
I am seeing one icon where it is written your screen sharing is paused. I don't know why is it happening.
Okay.
I'm trying once more.
No, your screen is being shared. I can see your.
Yeah, I just stopped sharing now, so you can just try once more.
Okay.
Yeah, maybe the technical, because Zoom we have nowadays not using that much. So just try once more. Now I can, because I am the host now, so you can try once more. If you have difficulty, you can just send me the slide.
Yeah.
I can share it from my side. Meanwhile, if Dr. Sridhar sir is ready, I think Dr. Sridhar sir, can you just start? I'll just introduce you also. Dr. Sridhar sir, I could not call you. I will introduce. Because technical glitch is there. So I'll introduce you. So Neeti, you can just send WhatsApp to me or mail me. Now it's coming.
Now
it's coming.
Neeti is coming.
Right. Good.
Neeti,
You
your
can finish
slide
it.
is coming.
Yeah. Please, you can go ahead. Please.
Okay.
Yeah. Over to you. Yeah.
But slides are not moving, sir.
I think
So
you're.
try to move once more.
Yeah.
I think
You can actually send me. No problem. I will try to my side. I will introduce Sridhar sir 1 second. Yeah. So get pleasure to introduce Dr. S. Sridhar. He's a professor and head of the Department of Endocrinology and Metabolism at Madurai Medical College, Madurai. He's also visiting consultant at Vadamalayan Hospital, Madurai. He actually is a very active member of ESI. He has been affiliated to the Endocrinology Society of Tamil Nadu. He's treasurer previously. He has got 44 publications in index journals, and he was the best outgoing student of MD at JIPMER, and he is also winner of the ESI TISA and EV Gandhi Award at national level at 2012. And he has also organized so many conferences recently as well. He recently was in the name because he also has introduced the ESI registry for the ESI. So he has got ESI President's Appreciation Award, and he has done his DM endocrinology from PGIMR, Chandigarh, sir. Okay, sir, over to you, sir. So he'll be shedding light on Graves' disease and anti-TPO antibody. TSH receptor antibody. Yeah. So stage is yours, sir. Over to you, sir.
Yeah, good evening, one and all. At the outset, I would like to thank the ESI organizing team for giving this opportunity to speak regarding this, the topic regarding the third generation thyrotropin receptor antibody. That is a trap assay for predicting neonatal thyroid dysfunction in pregnant women with Graves' disease. And this was done by one of my postgraduate as a part of dissertation, and it was published recently 6 months back. So just overview, the TRAB, that is a TSH receptor antibody. It is in the basolateral membrane of the thyroid follicular cells. And so the TSH is acting through the TSH receptor antibody, and various intracellular mechanisms, these excess thyroid hormones are synthesized. And this is a popular table from Williams. You see that the TSH receptor antibody is the most sensitive as well as more specific for Graves' disease as comparing to the thyroglobulin antibody as well as the thyroperoxidase antibody. And it is quite interesting that general populations will be negative, this TSH receptor antibody as comparing with the TPO as well as the thyroglobulin antibody. And so this, as comparing to the Graves' disease, this shows more significance as comparing with the other entity. And these are the various indications, but one of the most common indications is pregnancy with the Graves' disease. Even though because of the cost, it is not being used quite obviously as comparing with the other antibodies, but it is having more impact in the maternal fetal outcomes, and I will be highlighting. And whenever we have confusion about orbitopathy, again, it is more useful, euthyroid or unilateral orbitopathy. And hypothyroid orbitopathy, again, it is more interesting, and predictors of remissions, it is being used in the recent situations. And the conformations of Graves, again, it is one of the most common tests. And this slide shows that TRAB is one of the important biochemical markers. You see that it is crossed through the placenta and reaches the fetus, whereas the TSH doesn't cross the placenta, whereas thyroid hormones to some extent or most of the times it may crosses the placenta. So the TRAB is, as comparing to the other antibodies, this is the most sensitive antibody and biochemical test that crosses the placenta. So the aim of our present study was to validate the third generation TRAB assay for predicting the neonatal thyroid dysfunctions in Graves' disease mother. And our primary outcome was to assess the different forms of neonatal thyroid dysfunctions in relations to the maternal and the neonatal TRAB. And secondary outcome was to predict the adverse outcomes by using these maternal TRABs. And it was a prospective study, and it was conducted over a period of 2.5 years period. And so this thing is a government hospital, and we have huge number of obstetrics load, and almost we have 4,100 bedded and almost 1,000 delivery per month. And we got referral from almost all the 7 to 8 districts of in and around Madurai. Even though our every district has medical college, but we have the tertiary care referral, so we have all complicated cases, and even 1 or 2 maternal mortality is also being noted in our center. So that much amount of volume is there in our center. So we see almost a lot of cases of Graves' disease with pregnancy. And all pregnant mother with Graves diagnosed either before or during pregnancy were included. And exclusion criteria was previous thyroidectomy and already was radioablations we have excluded. And we measured total T3, T4, TSH and TRABs by ECLIA immunoassay. And all women were on propylthiouracil during the first trimester, and it was converted to carbimazole during the second and third trimester. And The aim was to keep the free T4 at a high normal level, because physiologically in the third trimester of pregnancy, you may expect the free T4 will come low, and even in physiology. And this is the systems, and we have this equipments is inbuilt in our Department of Endocrinology at Madurai Medical College, Roach Cobas, and this is the TRAB assay were done by these equipments, ECLIA, and as per the manufacturer, this thing, the cutoff value is 1.75 international per liter, and it was positive whenever this 1.75 above 1.75 with or without this level. And the measuring range were starting from the 0.8 to the maximum range of 40. CV was less than 6%. So this is the manufacturer leaflet informations, and sensitivity of around 97 and specificity of 99. So this is the this ECLIA analyzer. We use this TRAB, and it was one of the accepted this. And before going to the results and baseline characteristics, so we have two types of TRAB assays. This is from the literatures. So one is the receptor assay, and the other one is a bioassay. So the receptor assays, it measures the TSH binding inhibiting immunoglobulin, that is a TBII. And bioassays, they detect the functional property, whether it is stimulating or blocking. And as comparing to the second generation, and this our present study is a third generation. So it has high sensitivity, almost around 97% sensitivity with a 99% specificity. So the first generations nowadays not being used. It is a porcine thyroid membrane extract. Second generation is a bovine fluorescent labeled extract. The third generation is the current one, that is a stimulating antibody. So with this background, this is the baseline characteristics. So over 2.5 year period, we included almost 51 Graves' disease mother, and some of the cases around 25. The mean age of diagnosis, the 32, so predominantly is a pre-pregnancy onset Graves' disease, and subsequently became pregnancy and visited our center. And pregnancy onset Graves were almost 19, and the duration of hyperthyroidism that was there. So we noted almost 7 thyroid storms during our the follow-up of this over 2.5 year period till the time of delivery, and almost 5 have adverse pregnancy outcomes. So the live birth was only 46 as comparing with the 51. And so we compared the second trimester, third trimester free T4 as well as the TRAB levels again at first visits as well as the third visits. And this is the mean dosage of carbimazole during the second and third trimester. So obviously third trimester, there may be less requirement as comparing with the first or second trimester. So out of 51 women, 7 had thyroid storm, and all of them had very high TRAB levels, and I will be highlighting the TRAB cutoff at the later. And 5 had adverse pregnancy outcome in the form of first trimester abortion in 3 and stillbirth in 2. And the live birth rate was almost 90%. So the 46 neonates were born to the 51 pregnant. The median birth weight was around 2.75. So this is the neonatal outcomes. So among the 46 live birth, the neonate with the negative TRAB, it was almost higher, 24, and positive TRABs were 22. So among the negative TRABs, almost 20 were euthyroid. Even among the negative TRABs, some of the newborns, they have hypothyroidisms, and we just observed. And the positive TRAB, among the positive TRABs, only 7 had neonatal thyrotoxicosis, whereas 6 had transient hypothyroidism. So we could not differentiate the stimulating and the inhibiting TRAB by this assay third generation. That is one of our limitations. And euthyroid, even though the TRAB was positive, the newborn were euthyroid. That was being noted in 9. And so the central hypothyroidism is quite rare and reported, and also has been documented in our study. So this is the 7 neonatal thyrotoxicosis. It is the close follow-up data. So among the 7, only the last 2 are pregnancy onset Graves. Almost remaining all 5 are pre-pregnancy onset Graves, and the free T4 level and third trimester TRAB between the mother as well as the newborn. And you see that the very high TRAB levels were noted on the just before delivery, and it is a TRAB level comparisons of newborn. And 3 of the newborns we treated with the carbimazole, and we have good neonatology team also. And DM course of neonatology also is there. So we have good the team, and symptomatic newborn, they were treated with the carbimazole for the 3 months, and subsequently they were followed up, and all were become TRAB negative at over a point of time. And asymptomatic, even though the TRAB was positive and some amount of elevated free T4, we just observed asymptomatic newborn, and we didn't do the interventions, anti-thyroid drugs. Just we observed, and subsequently there have been no morbidity to the newborns. And this is the surprisingly, some of the cases have neonatal hypothyroidisms, but most of cases we were treated because the TSH was quite high. You see that the TSH of 28, 35, 50, but all are transient, the neonatal hypothyroidism. So it was been surprising that we were over treated at some point of time at the 3rd trimester of pregnancy. So almost everything has been crossed to the placenta and blocking antibody also. So even though the high TRAB, and it was high TSH also, and we have treated, and again everywhere we normalized at 2 to 3 months of time. So this is one of the first prospective study when we reviewed the literature, and the previous literature reported where already they were in thyroidectomy patients and they were received radiation ablation, whereas we have recruited all the newly detected or medical management people alone. And 3rd generation assays were used, whereas the previous literatures were 1st and 2nd generations, and all were followed up. That was the most important things. And from the time of inclusion of our study, everyone were followed up. And neonatology also we have good backup, and they were treated, and so everything were done free of cost. And so one of the important this thing, no comorbidities were found out. So it also affect the maternal and fetal outcomes and all forms of neonatal thyroid dysfunction. So the thyrotoxicosis alone is not the only manifestation to the newborn. It can be hypothyroidism, and it can be central also. And we did the multiple regression analysis to predict the outcome of that particular TRAB. And this was the important slide. And so you see that the just positive TRAB alone is just not going to be useful, because the 1.75 is the cutoff. And you see that maybe more than 3 times, maybe around 10, that maybe we can take it, or around 5 that may be taken, we can take it. So the 19, the maternal 3rd trimester TRAB, it has adverse pregnancy outcomes, so almost with the high sensitivity, with the specificity. And in neonatal transmissions, the neonatal thyrotoxicosis, again, this TRAB cutoff by ROC analysis, it shows very significant. And this almost, incidentally, these last 2 statistics were correlated. So almost the same cutoff, the neonatal 3rd trimester, neonatal 3rd day TRAB, as well as maternal 3rd trimester TRAB. And so the limitations was biological assays, they have advantage of whether positive, whether stimulating or blocking antibody as compared with the 3rd generation assays. That was the limitations. And so if it is 2nd generation is available, it will be well and good to differentiate all these things. So the very high maternal TRAB are strongly predicted the adverse pregnancy outcome, as well as the neonatal thyroid dysfunctions, and in pregnant women with Graves. And the thyroid function test in the newborn with the maternal and neonatal TRABs are strongly correlated with the different forms of neonatal thyroid dysfunctions, as well as very useful in avoiding inadvertent treatment. So many of the thyroid dysfunction are transient, so we have to close follow up, and many of the times mostly inactivity and just follow up alone will give to near normal thyroid function test. And this is the outcome of the paper. And Dr. Priyanka this year just passed out our 3rd year postgraduate, and she was the main primary dissertation, and it was published in the endocrine journal, and I was the guidance. And this study was conducted with the research grant from our ESTN of Tamil Nadu, and the part of obstetrics and neonatology department also helped to do this smooth outcome of these studies. So with that, I'm concluding. Thanks for the kind attention and opportunities.
Thank you, sir. It was a very good presentation. I think we have just yet to get more questions. So if any interactive points are there, please, Jabbar sir or others. Excellent study, sir.
Mohan, no questions in the chat box?
No, sir, because we are having the audience in another link. So we are just checking if anything is there because
Good evening,
yeah,
Sridhar.
because
Good
so
evening.
far we have not got any questions in the YouTube link. I'm also checking there. So we can just ask one of the questions if required, sir. Otherwise, we'll move on.
Can you hear me, Sridhar?
Yes, sir. Yes, sir.
Yeah, yeah.
No.
Welcome, Arun, sir. Hi, sir.
I just
Okay,
wanted to ask, have you kept the blood samples? Do you think you can do that? Is there an opportunity to do it on a second generation assay later?
But I'm not very sure. But we have the freezer. But I will just minus 40 degree. I will check it, sir. Actually, but I don't think all the samples will be available. Some may be there actually.
Yeah.
For the
Because
second
it might have been
yes, sir.
from what you said, it might have been a useful exercise if we did have that, just to compare and see whether your postulation would be right in terms of a better accuracy with those.
Mohan, is Neeti ready?
Yes, sir.
Yeah, I think now we'll move on to the next topic as there is no more questions. In case we have any questions, we'll take up in the end. If there is, because the audience are actually joining through a different link through YouTube, and this Zoom link is only for the panelists and the speakers. So we'll move on to the next
So far, we
topic.
have not got any questions. I just checked. Yeah, I just checked.
Yeah.
So I will present the slide from my side. Neeti, are you ready? I'll just try to load from my side. I hope connection is good here. Yeah. So I'll just start here. Is the screen visible from my side, Neeti?
Yes, sir.
You can
Yes,
just
sir.
start. You can start.
Okay.
You can
Good
say next,
evening,
I'll just move the slide. Okay. When you say next, I'll move the slide. Okay.
Okay. Good evening, everyone. I'm thankful to ESI for providing this opportunity to present this study entitled Effect of Morning versus Nighttime Administration of Proton Pump Inhibitor on Thyroid Function Test in Levothyroxine-Treated Primary Hypothyroidism, a prospective crossover study. So next. So as per Indian data, around 42 million people suffer from thyroid disorders, among which primary hypothyroidism constitutes to around 11%. So as far as optimum treatment is considered, more than 50% of these individuals who are on levothyroxine replacement have their serum TSH more than the target range. The causes of elevated TSH are innumerous, among which most important is non-compliance, the other being inadequate dosing, inappropriate timing of LT4 intake, including improper spacing with food, use of co-medications like calcium carbonate intake, ferrous sulfate, certain anticonvulsant or antipsychotic medications, and of course PPI. Next. So once LT4 tablet is ingested, it is then disintegrated and get dissolved in the stomach. The main determinant for this dissolution is the pH of the stomach, which should be acidic. And then later on, it gets absorbed in the jejunum and ileum. Next.
Yeah, I'm trying. Yeah.
Okay.
Getting stuck. Wait. Yeah.
So in clinical practice, we frequently encounter co-prescription of PPI with LT4 and as high as in 69% cases. The functional dyspepsia is quite common in these patients with primary hypothyroidism, as hypothyroidism may decrease the gastrointestinal motility. So these PPI are often prescribed by the healthcare providers or self-administered by patients themselves. The problem with the PPI is that they increase the intragastric pH so that the absorption of the LT4 gets affected. Also, the effect of the PPI on gastric acid suppression may to some extent may depend upon the timing of the administration of PPI. One of the previous study assessed the effect of the pantoprazole on the intragastric pH, and it found that when the drug is administered in morning, the intragastric pH remains elevated for a prolonged period of time compared to when the drug was administered in the evening. So next.
I'm doing 1 second. Yeah. Done.
So the main objectives of our study were to assess the effect of co-prescription of pantoprazole on TFT in over primary hypothyroid patients who were treated with LT4, and to determine the effect of the timing of the pantoprazole on the TFT in the same cohort. Next.
Yeah, I've done it. You can see.
Yeah. So the patients recruited all the primary hypothyroid subjects belonging to the age group between 18 to 70 years who had stable TSH for at least 6 months. And also, if there was any variation of the TSH, that had to be less than 1.6 or 40% change within the last 6 months prior to the baseline TSH collections were included. Also, these patients were on same dose of LT4, that too same brand, for at least 6 months. Subjects with chronic illnesses like CLD, CKD were excluded, along with those who were on certain interfering medications for at least 3 months, those who had history of non-compliance, known malignancy, and those who were known case of malabsorption syndrome. So those were excluded. So this study was a crossover 2-arm prospective study where the study participants were randomized into 2 groups, Group M and Group N. The Group M was the group which received pantoprazole in the morning between 6 to 7 a.m., while Group N received pantoprazole 30 minutes before dinner. Both the groups received LT4 1 hour before breakfast. So, for initial 6 weeks, Group M received the pantoprazole in morning, while Group N received it at the dinner time. Then, after 1 week, for 1 week, from 6 weeks to 7 weeks, this was a period of washout for pantoprazole. And after that, the 2 groups were crossover, so that Group M received 10 pantoprazole from 7 weeks to 13 weeks at night, while Group N received pantoprazole from 7 weeks to 13 weeks in morning. So, TSH was measured at 3 points of time: at baseline, termed as TSH1, at 6 weeks, termed as TSH2. The 1 week was a washout period. So, TSH3 was measured at the completion of the study, that is at the 13 weeks. So, period 1 was defined from 0 to 6 weeks, while period 2 was defined from 7 weeks to 13 weeks. Next. So, TSH was measured in the Advia Centaur XV Siemens platform. Next. So, regarding statistical analysis, to compare the change in the mean TSH within the groups, we used a paired t-test, and the change in the TSH was assessed from baseline at the end of 6 weeks and also from the 6 weeks to 13 weeks. And in overall cohort also, mean TSH was compared at baseline and 6 weeks and also at baseline and at the end of the completion of the study. In order to assess the TSH, once the patient is on pantoprazole at different point of time, we used repeated measure ANOVA test. Next. So, after matching inclusion and exclusion criteria, and excluding those patients who did not give consent. So total 34 participants were randomized into group M and group N, each containing 17 participants. However, in group M, 4 patients were lost to follow-up. So finally, group M contained 13 participants, while group N contained 17 participants. And the study was conducted over a period of around 2.5 years in our department of endocrinology at Medical College. Next. So coming to the baseline characteristics of the two groups. So the two groups were comparable on the basis of the baseline characteristics. We found a female gender predominance in our study. The mean TSH was also comparable in the two groups and was normally distributed. Next. So this here we can see the mean TSH concentration in the overall cohort, including both group M and group N. So at 0 weeks, the mean TSH is 2.42, which increased to 3.51 at 6 weeks to 4.2 at 13 weeks. And if we consider the difference between the TSH at the two different time periods, so the difference between TSH2 and 1 and TSH3 and 1 were statistically significant. Next. Among the individual group, as we can see, in group M, the TSH1, which was measured at the baseline, was 2.7, which increased to 3.78 at week 6 to 3.76 at week 13. Similarly, in group N, where the mean TSH increased from 2.2 to 3.3 to finally up to 4.53 at the end of 13 weeks. Next. When mean TSH concentration was compared at the different point of time, so we found a significant rise in TSH concentration across the study period. And when post hoc analysis was done, so a significant difference was found between the TSH3 and 1, that is at the week 13 and baseline, which was statistically significant. However, the changes between the TSH2 and 1, that is at 6 weeks and baseline, and between 13 weeks and 6 weeks were not significant. Next. When the mean TSH change was considered at the in the different groups, so we can see that their median percentage elevation in the serum TSH concentration from the baseline to the end of the trial in the entire cohort was around 33%. We also tried to look for the clinically meaningful changes in the TSH, and these clinically meaningful changes were described as if the absolute value of TSH was more than 4.78, that is above the reference range for the population, or if there was increase of TSH of more than 1.6 or increase of TSH more than 40% from the baseline. So what we found was that TSH level of more than 4.78 was observed in 26% of patients after 6 weeks and in 33% of patients after 13 weeks. Also, TSH elevation more than 1.6 or elevation more than 40% was evident in 40% of patients at 6 weeks and 50% of patients at 13 weeks. However, none of these changes were statistically significant in either groups, neither at 6 weeks nor at 13 weeks. Next. So coming to the the studies which are available in the literature. So there are a handful of the studies who have looked the effect of the PPI on the TFTs. Some of those studies were conducted in euthyroid individuals, while some were conducted in hypothyroid individuals, and the results of the study varies. In some studies showed that the PPI intake caused elevation of the TSH, while in other study, the TSH remained more or less same. Also, the duration of intake of PPI also differed. In some study, it was only for 1 week, while in other, it was for prolonged period. However, none of the study in the past has assessed what is the effect of the timing of PPI intake on the TFT, which was assessed in this study, as we assessed what was the effect of the administration of PPI in the morning and how it differed from when the PPI is administered in the evening. Next. So study had certain strengths and limitations. The one of the strength was that it was a crossover study. So it was a strong study design, and we included the patients with a strict criteria that as the patient had a more or less a stable TSH values within the last 6 months. The baseline characteristics were comparable. We ensured 100% compliance both for pantoprazole and NT4, and the drug as the compliance was ensured as these patients were asked to ingest these drugs under the supervision of relative. And also daily WhatsApp conversation was also provided to them. We excluded the interfering medications, and in addition, we also tried to look for the clinically meaningful changes in the TSH concentration. But the study has certain limitations as well, as the sample size was limited, and also 4 patients were lost to follow-up in the group A. This was a single center recruitment, and we had a washout period for pantoprazole only for 1 week. So these were certain limitations, and also we did not use a placebo. So these were some of the limitations of our study. Next. So to conclude, use of pantoprazole with LT4 causes significant elevation in TSH concentration in primary hypothyroid patients who are biochemically euthyroid. Such increment is encountered even after 6 weeks of the co-therapy, and this increment is was not dependent on the timing of pantoprazole use, whether it was morning or bedtime administration. Although statistically insignificant, such increase in TSH may be clinically meaningful. So we need future studies with larger cohort for the further clarification. Thank you.
Yeah, so excellent. So congratulations. So I think the YouTube, there is an issue because they are hiding the chat. So there are some questions they are personally messaged. Maybe if Lakshmi can take one question. Lakshmi is here. Okay. Sridhar sir, there is one question to you. So the question was that if you are doing a practical basis, what are the challenges we face? Do you do for everything practically? That's one question from an audience who has posted it personally to me. If you do it general practice, what is the implication of this test and TSH receptor antibody?
So general practice we don't do actually because of the cost. Because I think somehow now has cost come down, but I think commercial lab maybe 1,500 to I think 4,000, 5,000 they are charging this trap. But running cost is less only, not very much. Running cost maybe around 600 to 700. That is the running cost of this trap test. But because of this maternity, many patients they refer to the government institute because institutional delivery is almost universal in everywhere, and so almost we have a lot of benefits to the maternal this thing. So ultimately they land up in some hospital and they have some unique number and other. So in pregnancy, I think it is possible and to predict the thing. But in other situations, I don't do even. To stopping of anti-thyroid drugs also I don't, even though it is some of the commercial or private practice they've been practicing, but it is not that much amount of cost effective. But pregnancy again definitely to assess and to safeguard ourselves also it may be useful in some situations.
Yeah, because in COVID times I remember we had a problem with the technician scan. That time I think we relied on this TSH receptor antibody, and afterwards I think gynecologists are also tuned to sending this test. But as you told, it's a very individual decision, and institutional policy is also important. Moreover, if you are researched and your lab is compact enough, then it's easy to do. Thank you, sir. Lakshmi, there is a small question here. You have time? I'll just ask that question. Yeah. So newborn screening, there is a challenge in the cutoff values. So the question, because the chat box was not open in the general discussion, one question directly sent me is, what is the cutoff levels you do in practice for newborn and according to age in your practical scenario?
So like I mentioned in the study, more than 20 before age 2 weeks and more than 10 after age 2 weeks is the cutoff that we follow. But if it is more than 40, then we call for an immediate recall. This is as per the ESI.
So newborn screening is still a challenge, in your practice, in your area, it's still, is it actually done everywhere? I think India, I think 85% or more. No, it is not. An institution, maybe it's doing, no? The institution is doing. So the state-wise, it's not a very, state government institution, not. Thank you, Lakshmi. And I think question to Dr. Neeti, one small question. So every PPI has the same problem, because the question was regarding other use of other agents like what you call gelusil, or what you call that, that antacids or all the other things. No, is it a general blanket thing or is it only for PPI?
So it is predominantly for PPI. As patient may take H2 blockers like ranitidine, it may be taken if the spacing is done for at least 4 to 6 hours. So mainly it is for PPI, as it has a prolonged, the gastric suppression remains prolonged.
So that's the 3 questions which I wanted to tell. So over to the Joe sir. Any other questions? I think I did not find anything else in my personal message. Shall we move on? Thank you all the 3 researchers. I think it was a very good thing. So kudos to all of you. So you're doing a great job. Jabbar sir, any comments, sir, at the end of the first half? Thank you, sir. So I will just go to the next part of my this topic. So let me just load the screen. I hope it gets loaded. 1 second. Is it visible now? Yeah. So we have finished the first half of the discussion that has 3 research topics. So we'll go to the panel discussion on recent advances in clinical thyroidology. So we have with us eminent panelist and a good moderator. So I think Dr. Joe, can you introduce them? I will.
Yeah. It has been a great day for thyroid and also for the Indian Endocrine Society and the Indian Thyroid Society, because we have a lot interesting research topics, and now we are going to a very interesting session on advances in clinical thyroidology, and we have none other than Dr. Pramila Kalra to moderate the session. She is the professor and head of department of endocrinology at Ramaya Medical College, Bangalore. She's a big CV slide she's having. I'll just point out a few achievements. That is, she has had a very excellent academic career, and also she has won the A.V. Gandhi Award for Endocrinology 2018, A.R. Seth Award, ICMR Scholarship, and she's an executive member of Karnataka RSDI and also National Academy of Medical Science, FAC awarded in 2017, executive editor of Thyroid Research and Practice. So she is the apt person to ask questions in this panel. I welcome Dr. Pramila Kalra to moderate, and I think she's going to introduce the panelists. No, I'll only introduce it. Okay, we have 3 great panelists. Arun S. Menon, who is the head of department and senior consultant endocrinologist at Lisi Hospital. He was formerly professor of endocrinology at Amrita Institute and was the consultant in endocrinology Durham and Darlington NHS Hospital, UK. And there I must say that Darlington is a very beautiful city. MD in University of Newcastle, and he is the current secretary of Indian Thyroid Society since 2020, and a very eminent personality and a panelist. He is currently joining us from Bali, where it is the Asia-Oceanic Thyroid Society meeting is going on. Next person.
Welcome,
next.
sir.
Welcome.
Thank you, Joe.
Next, we have Saptarshi Bhattacharya. He's a senior consultant endocrinologist from Indraprastha Apollo Hospital. He is the ex-secretary of CEPHIS. He's an executive committee member of Endocrine Society and also honorary secretary of Endocrine Society of Delhi and ex-president of SPEED. And he has ESI President's Award of Appreciation 2021 and more than 90 publications. Welcome, Dr. Saptarshi, to the panel.
Welcome, sir.
And Nitin Kapoor, I think the slide is not sufficient to give his full CV. You need multiple slides. So he is a professor and head of Unit 1, CMC Vellore, and he completed his postdoctoral fellowship in endocrinology from CMC Vellore and completed PhD research in clinical and genetic indicators of obesity from University of Melbourne, Australia. And he's current ESI member, and also he has won Young Investigator Award from Sri Lankan Endocrine Society and Melbourne Research Society Scholarship, and MGR University Gold Medal in Endocrinology, and more than 300 PubMed Index peer-reviewed publications in national and international journals with a keen interest in field of obesity, metabolic syndrome, pituitary, and metabolic bone disease. So welcome, Dr. Nitin Kapoor, to the panel. I'm handing over the...
One more, sir. One more.
Sorry. Yeah, Sanjay Saran. Sanjay Saran is Associate Professor, Department of Endocrinology, SMS Jaipur. He was the organizing secretary of the beautiful ESICon of 2022, and he's Honorary Secretary of Endocrine Society of Rajasthan Affiliate, and also Executive Committee of Endocrine Society of India. He has 46 publications, 3 chapters, and has done more than 100 presentations, and he was awarded by Government of China for excellence in the field of medicine and received Jaipur Epicon 98 award. Welcome, Dr. Sanjay Saran, to this panel. So now I'll hand over the mic to Dr. Pramila Kalra to take over.
So do you have any screen sharing, ma'am, or is it early panel?
No, I will ask the questions. I think we
Okay.
have the questions.
Okay,
So thanks, Dr. Joe, for the kind introduction and introducing the experts as well. So we have an excellent panel today who will be answering some of the important questions in thyroid, because we know thyroid is such a vast topic. We cannot cover it in half an hour, but we'll try to discuss few of the important burning questions which are being researched at the moment, and we don't have clear-cut answers for that. So starting with Dr. Arun. So Dr. Arun, we know that subclinical hypothyroidism is one diagnosis where many people straight away think that we don't need to treat. But now we have different schools of thought coming in, and we know that there is now research happening in the field of subclinical hypothyroidism, and especially in younger population, where we know that there are studies now and there is data available to show that there may be some effect on the lipids, on the cardiovascular function, on the cardiac autonomic function. So, and alongside with that, the cognition. Because we know that when people are in their productive years of life, and even a moderate or a mild difference in the cognition can have a bearing on the patient's work output. So what do you think on these two aspects of subclinical hypothyroidism in your practice, as well as the information we have or the data we have at the moment about this?
Thank you, Pramila, for the question. I think it's a very long-winded question, and I think it's probably I know it's one of your favorite topics, and you have done quite a lot of work in this area as well. So I think we'll have to take this as in many parts, and then perhaps also I would like to hear the opinions of other panelists also, because I think this is something which we can, if time permits, discuss a little bit more than just one person answering. We know subclinical hypothyroidism and its effect on the two main, I mean, there are quite a few other areas that we would have to go into in subclinical hypothyroidism. I wouldn't touch that. For sake of clarity, I will stick to one, the cardiovascular risk factors and the disease, and the cognition. These are the two areas that you had asked me about. Now, there are two sides to this. One is, does subclinical hypothyroidism increase the risk of cardiovascular disease? And again, it's an area that has been studied in detail. I was actually looking through a review article by Dr. Salman Razvi from Newcastle just a couple of years back, I think last year or so. An excellent one. If you could look at it, I would suggest everyone goes and looks at it. He has tried to update the more recent studies in the last perhaps 10 years or so, looking specifically at all these areas. But in a nutshell, this is an area where there is still no consensus. In terms of the risk that subclinical hypothyroidism causes, there is definitely an increased risk of dyslipidemia. Now, whether when you treat it, there is a moderate effect on lipids, not a full effect, but a moderate effect on lipids, would that translate into cardiovascular risk reduction or benefit? One can't be sure at this stage. So it's an evolving area. there is definitely an improvement in lipids, but you would need more data to say that this is going to be definitely beneficial. This is number one. The second area where there is some positive result with treatment is in atherosclerosis and carotid intimal medial thickness. There is definitely some recent studies to suggest that CIMT improves with thyroxine treatment. Now, let me warn you, as Pramila had said, it's mainly in less than 70 years age group that we are talking about the intervention with thyroxine. Okay. In more than 70 years, and especially in more than 80 years, you really shouldn't be treating. And I think the current evidence would say that you would keep the TSH in and around 4 to 6, interestingly, in very elderly, I would say, so 80 to 85. Above 70, the evidence is not great in terms of intervening. So would you intervene at this point for cardiovascular disease reduction alone? If TSH is more than 10 with subclinical hypothyroidism, with TSH more than 10, yes, the data is very fairly robust, I would say. So you and I'm sure all our practice reflects that. Between 5 and 10, and perhaps in elderly between 6 or 7 and 10, I think there is still no clarity. So that is one area, the cardiovascular. In terms of obesity, nothing much has changed, as you know. We still don't use it, and I don't think there is any evidence to use it in those in that area of cardiovascular, cardiometabolic risk factors. Now, in terms of cognition, again, the data, if you look at studies, there is a lot of studies, and it's like a 50-50 split. There are a lot of studies that on one side supports that cognitive impairment could be due to subclinical hypothyroidism, or there could be a correlation. But intervention in terms of cognitive improvement, the studies are still not very convincing as far as I'm concerned. I would like to again hear other people's view as well on this. So this is where my point of view is, I don't think we have moved very much forward, although there are promising signs in the horizon in terms of subclinical hypothyroidism treatment being helpful in this in these scenarios. I don't think we still know how to treat it, at what level to treat it, and when to intervene, in which age group. So I think that data still needs to be clarified. That is my personal view.
Yeah. So thanks, Dr. Arun. So what we have understood from your talk that we might need to treat few of the patients, especially we know that if there is a rising trend of TSH, and if the patient has TPO positivity, family history, goiter, those are the cases where we might think of treatment, yes. And definitely if the patient has a dyslipidemia, high triglyceride, which is not explained by any other reason, and the most important aspect in this is less than 65. Above 65, we are very clear. There is not at all any data to show any improvement. On the contrary, it may cause harm. Even there is data with cognition as well as with other psychiatric issues, and they have shown on no benefit. But yes, the controversy is only for the younger lot, where we might treat for few indications. There are some studies with definitely, as you said, with cardiac autonomic dysfunction, atherosclerosis, but the long-term data on the cardiovascular mortality we don't have at the moment. So that's why we are not in a position to say firmly that we will definitely treat all. So obviously we won't treat all subclinical, but we'll treat few of them as a case-to-case basis. I think Dr. Nitin wants to add. Please, Dr. Nitin, please. Yeah.
Just a very small point. So as you rightly mentioned about obesity as well. So there are BMI specific cutoffs for normative ranges for TSH. And I think that is helpful. And as a way forward, I think we should have age specific cutoffs as well, so that clinicians can use it more easily. So that's the only point I want to add.
Yeah, absolutely. Point well taken. Any other panelists would like to comment on this, or we can go ahead, or anybody would like to comment? Otherwise, we can go ahead to the next question. So I think we'll move ahead to the next question, and then we can have one more discussion at the end of the panel. So Dr. Saptarishi, now we know that T3 is available in our country. And now every time the patient comes, they will ask also, the doctor, I need T3. Every patient says, like in Bangalore, in a city like Bangalore, we get so many patients who read about T3 and come to us and say, I think I need T3. That is the thing which is causing all the problems. So what do you think? Is T3 to be used for all, or there are very specific indications, like we know that myxedema, coma and all? Yeah, definitely we have to use and it is helpful. But do you think that some of these patients do need, and if yes, what are those specific indications where as an endocrinologist you will definitely offer T3?
So thank you, Dr. Pramila. That's a very, very relevant question. So these are all issues we have in our daily practice, like whether to treat subclinical hypothyroidism, whether to add T3 or not. So we actually, if going back to the last question, we have some data that after a TSH cutoff 8, so there are some meta-analysis which show that increased cardiovascular association with increased cardiovascular mortality. But again, there are no long-term studies which have suggested that you can give thyroxine and actually it helps. But going back to the question you asked me, that so why this controversy? So you very rightly pointed out that many of our patients who come to our OPD who have hypothyroidism, they will tell, I am not feeling well. So my TSH is normal, everything is normal. So and most of the times we don't have an answer for that. So that is how, so around 5 to 10%, if you can take, maybe that's an approximate number, but there are again studies suggesting that they tend to have persistent hypothyroidism related complaints in spite of adequate compliance and a normal TSH. So naturally, everybody tried other options, and T3, T4 combination has been tried in multiple studies. So as of now, if we go by the guidelines, as a routine, if you ask me, there is no role of T3 for a normal hypothyroid person. If you now move to those particular individuals where they continue to have symptoms, so there are again both ETA says, European Thyroid Association says that if you document compliance, if TSH is normal, dosing is adequate, in spite of that, if the person continues to have symptoms, you can give a 3 months trial of T3. So again, just to make our viewers aware that percentage will be 5 to 10. It's not everybody. So a very small subgroup might actually require a trial of T3. But again, going on to the trials we have, there are some RCTs, man, I wish that we have more because this is an unanswered area still now. There it has been shown that maybe 1-2 studies showed some benefit, but most of the studies actually have been neutral. So if you look into the recommendations for the guidelines, so they will be very, very guarded about using T3 as a standard treatment. So maybe there are some particular situations. So one is like a dehydrogenase 2 polymorphism of T29A. So that is a genetic situation. So we all know that T4 gets converted to T3 in the tissues, and that occurs in through dehydrogenase 2 in the tissues. So that particular subgroup, they did quite well when they were supplemented with T3 on top of T4. There are some other studies related to selenium related inversion sequence protein related modifications, mutation protein related genetic mutations. They also showed some benefit with T3. But again, to give a very straight answer, most of the patients will not require T3. You document that the TSH is normal, compliance is normal. And in spite of that, if the person continues to have symptoms, maybe there is a case for giving a trial of T3. Obviously, in very severe cases like myxedema coma, as you rightly pointed out, you can start T3 and then that will give a quicker and earlier benefit. But in most of the cases, you really still need to be guarded. Just because it's available in India, you can't try it out in all patients. Routinely, no, very, very selected patients worth a trial. If they respond, maybe you can continue.
Yeah, very nicely told, Dr. Saptarishi. So agree with you, because very, very specific indications, like obviously myxedema coma, patients prepared for surgery, or those are the specific indications. But yes, when you're talking about long-term use, we also have to see the benefit, whether it is actually this or something else, maybe a placebo effect. But yes, the best way out is if you strongly feel as an endocrinologist that this patient needs T3 and the symptoms are not getting explained by any other thing and the quality of life will improve, then you give a trial and see. But we have to watch for palpitations and other things. And especially older patients, we should be cautious. We should not offer them. This is only for the younger patients where we may think that this may be a beneficial thing, and watch for palpitations and any other problems. Rightly said. Anybody else would like to add something? Yeah,
Another
please.
point way of looking at it is that T3 dosing in most of the studies has been inadequate. So sometimes the dosing has been once. So ideally, you should be having a long-acting T3 preparation because it has a very short half-life. So we don't have that as of now. So most of the studies, most of the individuals will require dosing 2 to 3 times, and the studies actually didn't do it. So maybe the studies are still not in the right. Well, there is lack of properly designed studies with T3. If we have them, maybe we can give a better answer to this. As of now, very selected patients where we can use.
Absolutely agreed. Any panelists would like to add something, or any of the experts would like to add something on this? Otherwise, we can go to the next question. So I think we go to the next question. So Dr. Nitin, you have been doing a lot of work on MASLD and what we used to call NAFLD. So what do you think is the role of thyromimetics? Because we say there is a sort of intrahepatic hypothyroidism which happens. So in such cases, the role of thyromimetics, and we know now resmetirom has been approved recently for moderate to severe fibrosis. And what are the indications? Where exactly would you think these patients will benefit, or do you think that this is the future? Because we know that they have been used for basically dyslipidemia, atherosclerosis, but whether they actually translate into further reduction in cardiovascular mortality, again, we don't have the answer. So especially in these cases where you have these patients with MASLD, because we don't have much of options also to offer. So what's your take on this?
Absolutely. So I think a very relevant question, especially keeping in terms with the theme of today's session, talking of recent research. So looking at this from a basic science point of view, when we talk of thyromimetics, we understand what we've learned in physiology about thyroid receptors, the different types. There's alpha, beta, alpha 1 in the heart, alpha B2 in the pituitary. Beta 1 is the main one that we're talking here in terms of liver and fat. So the story of thyromimetics has been there for a while. I would say 10 to 15 years ago. Also, there was an article in IGM talking of the two drugs, sorbitrom and epitrodome. And these drugs were, again, mainly looking at LDL. So the whole concept is these drugs predominantly work at the beta 1 level and does not disturb the alpha 1 and alpha 2. So it's not disturbing the heart, the tachycardia that we were talking about. It's not reducing the TSH, but just specifically reducing the lipid or the LDL cholesterol by increasing the LDL receptors on the liver. So essentially, yes, looks promising and helps in MASLD in terms of the approval that it has got based on 2 recent studies that were published in Lancet and NEJM. And what has shown in these studies is usage of resmetirom in the dose of 80 and 100 milligrams has reduced the not only the stage of fatty liver disease, but even fibrosis. And as you rightly said, we don't have many drugs at this point. So yes, it has shown, but I must also flag a lot of caveats that we need to understand. First of all, it's not yet ready or available in India. The cost will be an issue. And the bigger question is we really don't know how long to use it, because this is a long-term chronic disease. And once we start, it's not that if it improves, whether we can stop. So I think there's still a lot more research needed in the field. And at the same time, we are getting a lot more other drugs for MASLD as well. So like GLP-1 RA. So I think at this point, it's still a gray zone. Yes, it has approved FDA approval. It is yet to come to India. The cost will be our constraint. And the bigger question of how long to use, we don't know. So I think, yes, interesting, but more research is needed.
Absolutely, absolutely. A very valid point, because we have new things coming up, and this is one of the new drugs which has got approved. But yes, we don't have it at the moment. But we'll see how the future is there, because we know that there is use with the HMG coenzyme A reductase inhibitors. And basically for dyslipidemia, these drugs were being promoted. And now we have found this MASLD and use in moderate to severe fibrosis as well. So now coming back to our initial thing to Dr. Saran, Dr. Sanjay, we were discussing about subclinical hypothyroidism and cognition and cardiovascular morbidity and mortality and autonomic dysfunction and dyslipidemia. But now coming to the similar group in the elderly, because we did talk about this a bit, that in the elderly, it may not be much beneficial, but still there may be few elderly patients with specific indications where you think that this subclinical hypothyroidism, especially the TSH beyond 8 or 9 or a rising TSH with some particular indications may benefit from treatment. So what's your take on that? How safe it is to treat? And if yes, then what targets would you like to keep? And which are those specific indications where you would think about treating these patients?
Yeah, thank you. Thank you, Dr. Pramila, for this question. As we know, this is a very important question nowadays. TSH increases with the age, that is also there, and it's a sign of longevity also. So in the elderly patient, we see subclinical hypothyroidism is very common in elderly patients. So treatment, as far as treatment is concerned, we know in elderly patients, if they do not have any cardiac disease or they do not have any other mortality or morbidity which increases mortality and morbidity disease like ACVD and other diseases like CV or something like that they are having. On those patients, we can start with full dose. In elderly means around 65 years of age. So one consensus is that. Other consensus is that we should start with lower doses, then we should increase the dose. So we know in the elderly patients, one side that the lean body mass is lesser, so dose requirement is lesser. Other thing is that absorption is lesser, so requirement still it is more in elderly patients. So other thing is that in lean mass patients, some comorbidities are also there. So we should start with some lower doses and we should build up the dose later on. Then come to the TSS levels. What should be the target TSS level in elderly? So in elderly patient, when the age is more than 70 to 80 years, in those patients, the TSS target should be in between 4 to 6. So it's a little bit more than the younger populations. So we know the chances of osteoporosis and atrial fibrillation are more in elderly patients. Even many of the elderly patients with subclinical hyperthyroidism, they present with the atrial fibrillation. So chances are more, so we should start with lower doses and we should gradually build up the dose. So other side is that if the patient is having age of more than 80 or 85 years like that, in those patients, if you see TSS level, so if it is lesser than 8 or 9, 8 is lesser than, so no need to treat those patients because according to age, as increases the age increases, the TSS level also increases. So in those patients, if say specific indications are there, like some dyslipidemia or some cardiac disease already there, and that time we should treat the patients if other causes of dyslipidemia are ruled out in those patients. So we should start with some lower doses and gradually we should build up the doses. One is that if we do not see any kind of morbidity in those patients or any cardiac disease not there, then we can treat with the full blown dose. One consensus is there. So still we do not have any RCTs there. Those have compared the lower doses, start with lower doses or start with full doses in those patients who do not have any kind of cardiac morbidity. Thank you.
Oh, yeah, rightly said that most of the elderly will not need treatment, except in very few indications, as you pointed out, where we might think of treatment, and that too, we have to see the cutoffs. We have to take the age-specific cutoffs and treat accordingly and go with a very low dose and not be too overzealous with the treatment initially. So going ahead with that, Dr. Menon, we already discussed about hypothyroidism and subclinical hypothyroidism with you. So now another indication of treatment, or I would say definitive indication of treatment of subclinical hypothyroidism is pregnancy. We know that that's one group where we don't discuss much about it and we just say, yeah, this has to be treated. So what do you think? We have the guidelines from the Indian Thyroid Society as well. So what is your take on that? Or what is your message to the delegates who are listening to this, at what level they should start and what should they keep as a target? And when a woman comes to them who is not yet pregnant, but she's planning for pregnancy and she has a TSH like 4, you say, and TPO is negative, will you treat that lady or you wouldn't treat that lady? So a clarity on that would be good for the audience.
Yeah, I think the treatment cutoffs have been fairly well defined for some time in subclinical hypothyroidism and pregnancy. the 2.5 or less than 2.5 in the first trimester and less than 3 in the second and third trimester has been, I think it's something which there's a consensus there in American as well as in European guidelines, as well as in our Indian thyroid guidelines, which you were very much a part of in making. Rajesh Rajput, of course, as we know, was leading that. So I think there's not been one of the deficiencies we all have, although there are studies from Rajesh groups and other groups in India, is that we don't necessarily have, we should have local cutoffs or local data, normative data, which we can use for drawing up the cutoffs. When that's not there, we obviously have to use whatever is available. So I think that is why I think we are all still using the 2.5 and the 3. In terms of subclinical hypothyroidism, that when they present before pregnancy, if they're subclinically hypothyroid, you definitely look at treatment and what is the cutoff. I think if they're antibody positive, definitely you would treat more than 4. And anything more than 4 of TSH, you should definitely treat with a positive antibody. And one of the things that you could do at the end of delivery and postpartum is that you could definitely look at stopping it. So that is, I think, one of the things, because out of the pregnancy scenario, there may not be any reason to continue to treat them. This is probably one area where we have, we might have to look at, because many times these patients continue the thyroxine afterwards. So there may not be an indication for that. But I think the cutoffs are fairly clear. Treatment is fairly clear. Now, one area where there has been more recent evidence is in the those who have recurrent pregnancy loss. And this is again something which we have again used, and also in assisted reproduction and for infertility and assisted reproduction, where definitely treating subclinical hypothyroidism with thyroxine has been shown to be useful. So those two are certainly areas where I'm sure we are already treating, and there is fairly decent evidence as far as I'm concerned. Thank you.
Yeah, very nicely said, Dr. Arun, because these things have been clearly defined even in the ITS guidelines, that a woman who is a high risk and definitely above 2.5 we have to treat, and most of the women we will treat above 2.5 as per the Indian cutoffs, because we don't have specific cutoffs for our population. That is a problem. If we would have had that, we would have taken a decision regarding that, but because we don't have, we go with 2.5, and we always say that there should not be any harm. So we don't go with a very high dose if it's very near the target of 2.5. But yes, even the guidelines say that it's better to err on the side of treatment rather than not treating. So that way, this is one group where we would err on the side of treatment most of the times, because there may be controversial things on the baby's brain development and IQ. Even with subclinical, we have data. So coming over from that to the another thing, which is very commonly nowadays talked about ever since, we know since 2016, this terminology came in of non-invasive follicular thyroid neoplasm with papillary-like nuclear features, that is the NIFTP. Now, previously we used to label it as a variant of the thyroid cancer, but now it came into that benign category. But we know that over a period of time, we have a lot of studies which have come up saying that this may not actually be always benign. Like, we know that it is benign, but the pathologist has to see properly the capsule. There should not be any breach, and necrosis should not be there. Otherwise, then it again goes to the other end. So we need to have a nuclear scoring, and studies have shown that 3 and the scoring and more maybe the thing which may tell that it could be having a potential for metastasis. So do you think that when we label a patient as NIFTP, can we all just tell them as a lobectomy and a follow-up? Or do you think some of them may need more aggressive approach? So what's your take on that with the latest data, what we have?
Thank you, Dr. Pramila. Again, a very, very relevant question. So, so as of now, this is a comparatively new entity. So it's considered as a very low risk thyroid tumor. So the earlier term was non-invasive encapsulated follicular variant papillary thyroid carcinoma. Since the risk is not that high, and the term carcinoma or cancer can actually be stigmatic and lead to unnecessary investigations and treatment. So as of now, the current terminology is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So first of all, what we need to understand that this has a very strict criteria. So you need to, first of all, the tumor should not be having any evidence of invasion. There must be a follicular growth pattern. So the papillary, there can be papillary-like nuclear features, but the cellular pattern should be follicular, and there should be less than 1% or no papillary appearance. And also other cancer variants like insular, oncocytic, tall cell, columnar, they should also be absent. And the entire tumor capsule should be reviewed by the pathologist to label it to be sure that there is no capsular invasion. And as you rightly said, that there should be no areas of tumor necrosis or increased mitotic features. So all these should be there. So the diagnostic criteria is strict. But again, what we know is that in the age of easy availability of ultrasound, the number of individuals who have thyroid cancer actually has grown up, and many of these variants are actually something like NIFTP. So as of now, as per ATA and most other guidelines, so if you have NIFTP, so the person does not require an adequate lobectomy has been done. So the person does not require completion thyroidectomy. The person does not require radioiodine. So that is the current evidence. There is confusion regarding whether we should be getting a serial neck ultrasound. Maybe that will be a safe thing to do. So if a total thyroidectomy has been already done, maybe the thyroglobulin can be considered as a follow-up strategy. Again, not much of evidence to strongly point towards that, but can be considered. So this is a comparatively new entity and not much of follow-up data. But one thing again is, it's sure that most probably this is something which we it's not that it's totally benign. It has a malignant potential. So maybe it was in the transition phase from a benign tumor to a malignant tumor. And if you are able to diagnose at this particular point and able to do a complete resection with adequate, and you are able to see that the whole capsule is intact. So most probably as of now, we can just very safely follow up with imaging. But had it been left, so most probably it has the potential to grow into a malignant thyroid cancer. So as of now, if we have a proper confirmation from the pathologist, so we had a patient who was recently operated at a large goiter. So we got and with a retrosternal extension, and the operation was done more for the compressive symptoms. But once the thyroid was taken out, so there was one area which showed actually NIFTP 3 to 4 centimeter tumor. But we had a discussion with the pathologist, and she was able to confirm that no, it's NIFTP. We have it fulfills all the criteria. So in those cases, you just maybe need a serial ultrasound, and if you have done a thyroidectomy, the total thyroidectomy may be a thyroglobulin. And again, there is no need to suppress TSH as we often do in moderate risk or high risk cases of thyroid carcinoma. In this case, you can maintain TSH in the normal range with thyroxine replacement. So as of now, a safe entity. We need more data to be sure that it does not have a potential for conversion to malignancy. But whatever data we have is reassuring. So if an adequate lobectomy has been done, it should be fine.
So I think, as you rightly pointed out, a discussion with the pathologist in such a case is very important, because they should see the capsule that there's no invasion and there's no evidence of necrosis, because any of these two would be markers that they need more aggressive approach. And sometimes if the pathologist has done a casual approach, then it may be a problem. So that's why a discussion with the pathologist would be the best thing to do, as you rightly said. And that's what most of us, I think, prefer to do as well. So going out from there, now we know that we get so many patients with thyroid nodules, Dr. Nitin, like Dr. Saptarishi pointed out, that many patients do ultrasound, and we are finding nodules almost in so many patients. And that's a usual thing, because they'll do the ultrasound and come to you. So now what is the next step? Because we know that liquid biopsy is one of the things which has come up in a big way, and we had a lot of data coming from Dr. Sujay on this. So what's your take? Are you doing it in your center, and how do you advocate that, and where all we should do it? What exactly it is also for the delegates to understand.
Right. So very important question. It's another very upcoming field in the domain of thyroid research. And what I would say is, yes, after we have a thyroid nodule, as you rightly said, maybe 1 in 10 or 1 in 5, 1 in 8 people in the general population may have a thyroid nodule if you screen everybody with the ultrasound. And though ultrasound is good and it does give us now very good scoring systems to predict malignancy, but many times we are in a dilemma whether this needs operation, doesn't need, especially in the borderline cases. Now, the conventional way has always been to do an FNAC, which is a biopsy, which is invasive. Also, it just tells us the quantum of tumor, but does not really tell us how it's going to really progress with respect to treatment effectiveness. If I'm using that for follow-up, it doesn't help. It just tells me what sample I've got and how bad that sample is. The overall picture of a tumor load is not given by an FNAC per se. But that's where the role of liquid biopsy comes. Now, just for people who have not heard about it before, this is something like a real-time diagnostic tool where we are trying to assess circulating tumor DNA in the blood, in the plasma or the serum, circulating tumor cells and certain exosomes, which can be measured and can give us an idea whether a particular mutant genome is circulating in the blood, and whether that can tell us about not only the type of tumor, but also the tumor load, not only at baseline, but also in follow-up. And the best part is this is non-invasive. It's just through a blood test, not really requiring an FNAC. Now, talking specifically with respect to the research that's done for thyroid nodules, yes, it's been used for PTCs, the papillary thyroid cancers. Mutations of BRAF have been seen. The genes for BRAF, SLC, 5A8 and certain specific genomes have been studied. But I'd also like to highlight that this has also been used for MTC as well. And though we do have good tumor markers for MCT like calcitonin and CA, but even the RET 918 has been helpful. At this point in time, we're just wanting more literature at our center. Right now, one of my PhD students is working with me on this as a research project, but we don't have a lot more evidence as to how this is going to be in the Indian scenario. A lot of good work from Calcutta by Dr. Sujoy Ghosh group, and we just hope that we have more literature and this should be in practice very soon.
Yeah, definitely. I agree, because one of the best things to diagnose, and it's a non-invasive, we can say, in a way, because we are just taking the blood and we can do it. The other liquid biopsy can be done with other fluids, but especially not for thyroid, but for other things. So just one last question with Dr. Sanjay, because we see so many children nowadays coming with a TSH report of 6, 7. Parents do it just like that. Child is growing obese. They do one TSH and they bring a report of 6 or 7, or the child is not growing and they bring a report of 5 or 6. So what do we need to do in such cases? Do we need to treat all these children, or we blanket wise we say no, we don't need to treat? Or do you think that we need to follow up these kids, or do we need to do the antibodies? What do you do, and what is the protocol? What should we follow in such cases?
Yeah, kids with the subclinical hypothyroidism now is a very common entity. We see in OPDs, a lot of patients are coming, just like adults. Particularly females are coming that I'm getting obese, so please do thyroid function test. So like that, kids are also coming with subclinical hypothyroidism. So treatment is not different than young adults, in kids also. In subclinical hypothyroidism, we don't treat the kids until unless some specific problems are there, because in most of the cases, in around 80% of the patients, we see thyroid functions normalized in subclinical hypothyroidism when the TSS level is less than 10. So particularly the patients, when they are having some problem in the growth, or they are having some other autoimmune disease like diabetes mellitus or celiac disease, in those patients we need to treat the subclinical hypothyroidism. Or sometimes the patient is NTTP or positivity is there, then also we need to treat. Or patients, kids are having some goiter, at that time also we need to treat the patients. Otherwise, we do not need to treat the patients. One thing is that in many obese patients, obese kids, we see thyroid functions are deranged. They are having subclinical hypothyroidism. In those patients, we should encourage the parents to decrease the weight, just to lose the weight. So once the patient will lose the weight, the thyroid functions test will be normalized. So it is because of the obesity that causes the subclinical hypothyroidism. But the patients, general population, are thinking their patients are getting weight because of this hypothyroidism. So it is just opposite things. So that's all regarding the management of subclinical hypothyroidism in kids.
Thanks, Dr. Sanjay. And I think Dr. Joe has already told that we are exceeded the time. So I hand it back to the organizers. And if there are any questions in the chat box, the panel can definitely take that.
Mohan, is there any questions remaining?
No. They are actually blown over by the panel. Beautiful panel discussion.
Yeah, actually, I was also very much listening to the panel, though I was worried about the time factor. That's the part of the organization part but my knowledge part actually wanted the panel discussion to continue. But anyway, everything that is great and good has to come to an end, and we need to have a set time limit for that. So today we had a very nice meeting, though it was decided in the last minute. First of all, let me thank Jabbar sir to bringing up the idea, though in the last minute, that we need to have a CME from Endocrine Society to commemorate the World Thyroid Day. And also, the only sad part of it was that we were not able to involve ITS completely, though we could get Arunesh Menon and Pramila Kalra madam and myself and Mohan Shanai also being part of ITS. So we are all a single family, but though officially we were not able to make them part of it because most of them were in Bali and we were not very sure how it would be possible to do it in the last minute. But anyway, finally everything turned out well, and I would like to thank our president ESI Jabbar sir for doing everything and putting up the idea, and KVS sir, who is our secretary Endocrine Society of India, to support it and also entrust it to me and Mohan to arrange a program in the last minute. And for that, I should thank all the speakers and the panelists and the moderator here, who in the last minute immediately agreed to be part of this program, as it was an ESI program. All of I wouldn't name individually, but I would like to just say that most of them were having some or the other assignments. Actually, if you see, when we were making the panel, the speaker list and the panel list, a lot of people who are there currently actually initially said that they already have some other assignments, and then came back to us saying that, see, I have just shifted that somewhere, or I just thought that I'll be part of ESI. That's a spirit that I loved maximum when I organized this. And Mohan's energy is something that you cannot match by any level. So finally, it was all a success just because of the wholehearted effort by the president, secretary, and Mohan, and all the speakers and panelists. And finally, not the least, the support from the Endocrine Society members who have made it a success with finally. So thank you very much for being part of it. And let me wish ourselves a very happy World Thyroid Day. Thank you.
Thank you.
Thank you, sir. Signing off.
Thank you, everyone.
Have a safe weekend.
Thank you.
Enjoy Bali. Arun.
Happy Bali.
Yes.
Thank you.
Thank you. Thanks, everyone.
I'll close the session with the permission of the chair, and thank you very much.
Thank you.